Now, the second presentation that I want actually to give to you relates to new developments in cardiology. And I put a little bit of a title like that, our heart, what's new? Well, there is a lot of new. And, in fact, I have been so lucky to live this 50 years that I'm now doctor and to see, how cardiology have changed from quite passive specialty that it used to be in the past to a very, very, very proactive, actually, specialty in the treatment of the problems of our patients. And in these 50 years, many, many, many things have happened. Just think about the treatment of myocardial infarction. When I was a resident, the patients actually were put in bed for 15 days. Nothing was happening. They developed the myocardial infarction and later on the whole complications. And we treated the complications instead of treating the problem. And nowadays, as you know very well, we actually just perform an acute PCI. We put a stent in the coronary artery that is occluded or that is narrowed, and then the patient, even 1 day after this or 2 days after that, goes home without a myocardial infarction. So there have been a lot of developments, but what I would like to concentrate is on the developments of the more recent time. Just actually to give you again from the point of view of someone who has been a general practitioner, what I believe is very important for a general practitioner to know today about what's new in cardiology. Okay, going to show you some high-tech things, but also, very simple things like new therapies, etc., etc. Now, to understand what has happened, there have been some milestones in cardiology. The first one has been the development of super specialties and even now super specialties. You know that we cannot talk anymore about cardiology. In cardiology, we have now three types of cardiologists. We have the guy from the mechanics of the heart, which is taking care of the heart muscle and the valves. We have the electrician of the heart, which is the electrophysiologist taking care of cardiac arrhythmias. And we have on the other side the plumbing of the heart, the plumber, who is taking care of the coronary arteries. But even within these super specialties, we see now people in super specialties. If you take now cardiac arrhythmias, my super specialty, then you see that you have the cardiac genetist of cardiac arrhythmias taking care of genetics. You see that there is someone taking more specifically care of patients with pacemakers and defibrillators, and you see the one that is performing ablations, and even in the group of people performing ablations of cardiac arrhythmias, we have people specialized in arrhythmia like ventricular arrhythmias, ventricular tachycardia, and others specialized in the treatment of atrial fibrillation. And this is, don't forget that, to the benefit of our patients. This is good, is maybe for the physician a little bit less good because you are becoming so specialized that you might lose the helicopter view of everything that's happening. But on the other side, is extremely good for the patient because you have highly trained specialists in each area of cardiology. Second thing, and it's very important recently, what has happened with new medications that have come to our hands for many different issues. I will discuss that with you. We have also now a big of improvements in terms of the coronary and structural heart disease and the hemodynamics of all these problems. Electrophysiology, I was also mentioning. Imaging has done tremendous entrance into clinical cardiology, as you know very well, but also in arrhythmia and in other areas of cardiology has become extremely important. I'll show you some examples of that. And of course, the last but not least, we have now a series of new ventricular assist devices that have also changed the life expectancy and the results of the treatment of many patients with advanced heart failure. Now, let's go through it. The development of super specialties and super specialties. What I was telling you, look, I just made here now a list of the different actually super specialties that we have. Clinical cardiologists, we have an acute coronary care physician, we have interventional cardiologists, we have electrophysiologists, we have the cardiac and vascular imaging specialist, the heart failure specialist, the hypertension clinic, the hereditary cardiovascular diseases, the grown-up congenital cardiologist, pulmonary hypertension clinic, preventive cardiology, cardio-oncology, and I can tell you that now recently, because of the new developments, we will have another super specialty, which will be cardioimmunology, because of the roles of autoantibodies in not only in actually infectious diseases like issues like the COVID and myocarditis and so, but even in cardiac arrhythmias, autoantibodies in cardiac arrhythmias. We'll come to that. Now, let's start by drug therapies. I'm not going to mention everything. I think that the most important things we have now got in our hands are the new oral anticoagulants and the new anti-diabetic drugs, and also the role of the statins as anti-inflammatory drugs in cardiovascular diseases. Now, new oral anticoagulants, what is the main advantage of this new anti-oral coagulants? The most important advantage is, of course, that we have now a reliable treatment that is actually completely different of the coumarins, that we had in the past, which were unreliable in terms of results. Remember that in any trial that was published in cardiovascular diseases where coumarin was involved, we were happy if 1 out of 2 patients was actually well controlled, 1 out of 2 measurements. So this was a disaster, but that's what we had. Nowadays, with the new oral anticoagulants, we can effectively treat our patients with less side effects. And as you know very well, the profile in terms of bleeding and efficacy is much better than the old oral anticoagulants. So of course, I don't need to tell to you that we have, with exception of valvular heart disease, where still we do not have trials that prove that new oral anticoagulants are effective. But with this exception of valvular heart disease, I think that every single individual that needs anticoagulants should use the new oral anticoagulants and not the old ones, unless, of course, there would be a contraindication to their use. Now, there is a very important thing I want to mention to you, and is we have not to forget that these new oral anticoagulants, they also work very rapidly. It's not the same like the coumarins. The coumarins, we had to give them for 5, 6, 7 days, even longer sometimes, before they were starting to work correctly. The new oral anticoagulants, when you give a tablet to your patient, within 2, 3 hours, the patient is anticoagulated. And that makes it possible to use a strategy that I'll mention later on, which is the pill on the pocket strategy in oral anticoagulation. You do not need maybe all the time to give every single day the anticoagulant to your patient if he actually has only from time to time paroxysmal atrial fibrillation, or if you are worried about that might have atrial fibrillation. If the patient feels the arrhythmia, you may very well tell to the patient, if you feel it, just get your anticoagulant immediately at that time and that day. But if you do not have any arrhythmia, maybe you don't need that day to take your oral anticoagulant. I know this is a little bit controversial because there are no studies, and I'm sure I will never be invited to tell that to congresses because this is against the financial benefits of the industry. But I think that there is a possible approach with the new oral anticoagulants to this pill in the pocket approach to the treatment of atrial fibrillation. Second important thing has been the advent of these new anti-diabetic drugs that we can use for the treatment of heart failure. Now, the most recent data, and this data have been just published last week, tell to us that the earlier that you use these new anti-diabetic drugs for the treatment of patients with heart failure, the more benefit that you'll get. So we are now, at least in our country, using the standard therapy and will move to these new oral antidiabetic drugs for the treatment of heart failure as a second choice when the patient is not going well. Now, everything suggests that we should be much more aggressive by using these drugs much earlier in the treatment and not waiting until the patient is not responding to the classic treatment with beta blockers, diuretics, etc., but use these anti-diabetic drugs as soon as possible. Now, just show you some examples of these oral antibiotic drugs. We have one additional benefit, and it's in fact that they also are protecting the renal function of our individuals. And this is shown very nicely by the conclusions of this. If you look at the two different types of new oral antidiabetic drugs that we have, the so-called GLP-1RA and the SGLT2I, they both reduce the major cardiac events to a similar degree, both in patients with arteriosclerotic cardiovascular disease. But when you are using actually these different types of oral antidiabetics, you have to realize that actually the SGLT2I, they have a much better effect in preventing hospitalization for heart failure and particularly in the progression of kidney disease. So when you actually have a patient with renal dysfunction, we should prefer these drugs. And as I was telling you, this should be done not as a second line therapy, but everything suggests that we should go as a first line therapy at the present time. As I said to you, in these 50 years, we have seen in the majority of countries the end of myocardial infarction. And this is thanks to the fact that we are able to go into the coronary arteries acutely and open that stenotic vessel during acute myocardial infarction and prevent that damage to the heart. Now, of course, I know that there are countries like mine in Belgium where we have, one hospital on every single corner of the street, so that this access to the hospital is extremely easy, and that there are areas in the world that the access to this acute treatment of myocardial infarction is much more difficult. But still, we have to realize that if we have the possibility, the way to go is as soon as possible to open the coronary artery. The problem of myocardial infarction is an occluded coronary artery. What we did in the past was treating the complications. What we are doing now is treating the cause. Open the coronary artery as soon as possible. Now, we have seen a lot of new things related to hemodynamics and coronary angiography. We are now doing a radial access, which is much more comfortable for the patient. We can evaluate the function of the stenosis if we measure in the coronary artery what we call the functional residual flow, which is basically a measure of the flow over the coronary artery. We can look at the intracoronary anatomy. We can even go to disobstruction of chronic occlusions, occluded coronary arteries that are occluded for many years, can even be disobstructed in more than 90% of the cases. So there are a lot of different things. Maybe some of them were promising and they are not that interesting, like stents that bioabsorbable. It makes not much difference. In fact, we have now simply just gone to simply a situation that there is no excuse to leave a patient without the necessary coronary angiography to clean and to open and to reopen the coronary arteries as soon and as much as possible, because this has a real impact on the long-term results for the patient, in the sense of these coronary arteries will not become better by themselves, but once we interfere with this natural history of coronary disease, then we can actually bring the patient to, let's call it, a normal life expectancy. The important thing is that we are getting more and more insights also in microvascular dysfunction. Why is that important to the general practitioner? because I remember also myself as general practitioner and even later as resident in cardiology, I was very disappointed by these patients that have the typical symptoms of angina pectoris and that you do not find anything in the coronary anatomy. The coronary arteries are completely normal. This is very disappointing. We are understanding more and more that these patients might have microvascular dysfunction, and a lot of new technologies and studies are being used at the present time to assess this microvascular dysfunction. And I think that we will all see new therapies, not, of course, not stents, not coronary interventions, but medical interventions to actually also treat these patients with angina pectoris, normal coronary arteries, but microvascular dysfunction. So don't be disappointed. It's not that you made a wrong diagnosis of angina pectoris. It is that some patients have microvascular disease that actually cannot be treated with the present techniques of stenting, etc., etc. Your diagnosis might be correct. The problem is the etiology of the angina pectoris. A structural heart disease. I'm just going to mention one thing, and as you have seen the evolution of TAVI, the implantation of an aortic valve from the groin, a percutaneous technique, so that you actually just change the valve of your patient with aortic stenosis without opening the chest. Now, we started with actually patients at extreme risk, patients that were old, that had heart failure, they had a renal disease, there were many things that made surgery not acceptable for these individuals because of the high mortality. And then from extreme high risk, we went to high risk individuals, then we went to intermediate risk, and I can tell you now at the present time we are doing that even in the low risk individuals. It's becoming the standard of treatment because of the benefits of not opening the chest, the thoracotomy, not having to open the whole chest of our patients to change the valve. So you see, that has been an evolution in a few years. We have, the TAVI, the transaortic valve replacement. This actually has not it's not a history of 50 years. It's a very short history, and because of the high tech that we're using at the present time, we are moving from really very limited indications in extreme high risk patients to actually going to any patient with aortic valve disease. And that probably you'll see that if also the cost of the procedure, etc., go down like it's the normal procedure, the cost as usually very high at the beginning of a new procedure, but then with time they become less and less costly. Then I think that this will be basically what will be happening in the future. But just to mention also, not going to go into detail of all this, but we can do almost anything you want in the heart nowadays. We can close almost any hole, perivalvular leaks, the ventricular and atrial septal defects. We can close the left atrial appendage. We can put paraplus, in the patent foramen valve in patients with cryptogenic stroke. We can put a valve in a valve. The mitral clip, alcohol ablations. We can, everything seems possible at the present time. That means to me that once we have all these technologies available, we as general practitioners, our role is to really actually be aware of it, to in fact refer our patient to the appropriate physician for the appropriate treatment. In cardiology, almost everything is becoming possible. So let's be open to it and do not keep the patient, with any cardiac problem longer and longer and longer without providing, this high-tech support, high-tech treatment that is possible nowadays, because almost everything can be corrected, treated, and even cured in cardiology at the present time. Look at electrophysiology also. What has come now? Ablation that started, as you know very well, about 40 years ago with very rough procedures. We had not much. We had catheters that were very difficult to manipulate. Now we have steerable catheters. We have new generation pacemakers. We have cardiac resynchronization therapy, which, to be honest, I believe the most important contribution of the rhythmologists of electrophysiology to cardiology has been the development of cardiac resynchronization therapy. What is that? You know very well what it is. It is simply the patient, usually who has heart failure, usually caused by hypertension, who has left bundle branch block on the electrocardiogram. This causes, instead of the normal contraction of the heart, causes asynchrony, first right, then left, then like this. The heart goes into heart failure because it's not contracting well. And if we actually put a pacemaker that will stimulate the area that is activated late, at the same time, we resynchronize the heart. And when we resynchronize the heart, we correct heart failure. And you know that we have even one expression in this treatment of our patients, what we call the super responders. People, you know, who have this hypertensive heart disease, left bundle branch block, heart failure, have a lot of drugs, they get this cardiac resynchronization pacemaker or defibrillator, and then once we resynchronize cardiac contraction, you can even stop all the drugs, except, of course, the ones against hypertension, and so they are really super responders. They get out completely of heart failure, the function of the heart recovers completely. So you have to have this knowledge and you have to give this opportunity to your patients. When you see hypertensive heart disease with left bundle branch block, think always, is this a candidate for resynchronization? Of course, as general practitioner, you cannot do more than that, but once an echocardiogram will show that the heart is contracting like this, what we call rocking heart, like the heart is dancing rock and roll, and you know you will resynchronize this, you will have your patient cured. We have other things, we have monitors, subcutaneous defibrillator, and now we are coming to something very important related, for instance, to the question that was asked about this athlete with a possible prolonged QT, but who had palpitations. We have watches and we have monitors, biomonitors, and actually little monitors that we can implant to our individuals, to our patients, to actually have an electrocardiogram at any time that we want, 24 hours a day, 7 days a week. Yeah? Now also we have in electrophysiology, but this is more just to show you how the things are improving, not for us as general practitioners to use, is all the new techniques that allow us to perform ablations almost without radiation, without using fluoroscopy, which of course is of benefit to our patients because of the dangers of radiation. Even if it's just a little bit of radiation, every piece of radiation that we can avoid is always good. Okay. Now, let's see here about imaging in cardiology. I believe that the most important thing we got at the present time is the coronary scan, the CT scan. There are other things, isotopes, holography, magnetic resonance. I'm going to concentrate to something which I believe for us, talking about general practitioner, is very important. When we have a patient who has a family history of coronary disease, is 60 or 65 years of age, and comes to us, and says he wants a checkup. What are we going to do? What is the value of performing an exercise test to a patient who has actually no symptoms at all, but because of the family history, maybe because he's also smoking, maybe he has hypertension, some high cholesterol and everything, says, I would like a checkup of my heart. The most important thing that we are missing is the coronary anatomy, the coronary arteries. We can look at the electrocardiogram, which might be normal. We can even have an echocardiogram, if you like, that can be normal. But then what are we not seeing? What we do not have in our practice, what we don't see in our consultation, are the coronary arteries. So we used to perform an exercise test. And if the exercise test was normal, then we say, oh, that's fine. But well, the value of an exercise test, we have come to learn, is extremely limited. Nowadays, we have the coronary scans, the CT, the computer tomography of the coronary arteries. And just let me show what we can get now in 20 minutes, yeah, without any pain or anything, because that uses the normal X-ray and simply a little bit of contrast, and we can get these images. This is the high-tech CT scan of the coronary arteries. And what do we see here? We see the aorta in blue, and then we see the right coronary artery, we see the main stem, the left main coronary artery, then going and dividing into the circumflex, and here we have the descending anterior and the diagonal branch. Now, this is not only a scan, this is also, at the present time, it is also possible to measure the flow in the coronary arteries. Now, let's look at the right coronary artery. This is blue here, that is 1, yeah? And then we have these numbers that tell you the percentage flow as compared to this aorta. So the more to the other side of the spectrum goes, from dark blue to lighter to green to yellow, the less flow, which is normal here because the artery is getting further and further from the aorta. But then you see, then this is not a problem at all. Now let's take here this diagonal branch. You see here clearly a narrowing. You don't need to be an expert to see that there is here a narrowing, and that all of a sudden the color changes to red, and that the flow has gone down below actually 0.8. This is the ratio between this and there. Yeah. So this is an stenosis, a narrowing, which is important. Look at here. This is also very important because if you look at this vessel, okay, it's narrowed. It doesn't look that narrowed. I mean, if you look at it, it's not like this. Here we have a clear stenosis in the coronary artery. We see the change in flow, but we have no problem at all. But here, if we would not measure the flow, we would think, okay, yeah, it is narrow, but I don't know. Well, but once you measure the flow, you see, in fact, that this is also decreased below the range of 0.8, which is still the normal range. And in fact, once you look much more carefully, if you look at this artery here, you see the diameter here, it's more than the diameter there. And that, in fact, this is a very long stenosis, which, if in the first impression is not that bad, but because it's very long, it reduces the flow significantly. In fact, actually, what was done here after this was to put a long stent and another long stent in this descending anterior artery, the left anterior descending, and put a stent into this diagonal branch. And the problem is solved. Now, I tell you, this individual was completely asymptomatic, had 3 exercise tests performed. They were all normal, including an exercise test with echocardiography during the exercise test to look at the left ventricular function. So the conclusion of the exercise test was that there was no problem. Once you had your coronary scan, you saw that there was a real problem. And actually, in fact, afterwards, when the patient was asked again about symptoms, at the end, he realized that some discomfort in the chest that he actually had overseen that. He was not telling us that, in fact, he had symptoms. He thought he had no symptoms. But retrospectively, he started to recognize, wow, I'm feeling now much better. I can do a lot more than I was able to do. I actually did not realize that I had pain. So this is actually the value of this coronary scan. 20 minutes is actually much more, of course, effective than an exercise test to recognize coronary artery disease. And at the present time, you do not only get the anatomy, but also the function of the coronary arteries during this procedure. Now, more milestones in cardiology. The assist device that I was mentioning. We can use now, and this is important, as a bridge to transplant in some patients, or as a bridge to recovery. Why do I mean a bridge to recovery? Now, you know that, among other things, one of the most important epidemics we have had at the present time has been COVID. And you know that COVID, in fact, can cause a lot of problems with the lung, but it causes also a lot of problems with myocardium, so myocarditis. And in fact, I gave a lecture about COVID and heart in Belgium for the general practitioners, because one of the most important things we learned from the COVID epidemic in relation to mortality of COVID was overlooked most of the time, and was we concentrated a lot on the lung problems, because the radiographies and the X-ray, the images that we saw with these balloons, white balloons in the lungs and everything, they were tremendously impressive, without any doubt. But in fact, we forgot completely that one of the most important factors in prognosis was at the moment of admission of the patient to the hospital to measure the troponins. As you know, the troponins, which are elevated in myocardial infarction, they are actually a marker of myocardial damage. When you measure the troponins at admission of a patient with COVID, if the troponins were elevated, this was one of the most important markers of actually a poor prognosis of this patient in the intensive care unit. So one of the things that happened then was that we had to treat these patients with everything we had, particularly when they went into heart failure. And the assist devices helped many patients as a bridge to recovery until they recovered for COVID disease. And in the future, maybe in the future, we have to keep that in mind, could be also a destination therapy. What do I mean by that? The devices that will be implanted permanently to actually take over the function of the heart. Now, just let me show you a couple of examples of developments that we have in terms of pacemakers and defibrillators. The technologies have also changed a lot. For instance, we have now, in terms of the pacemakers, we have electrodes that can monitor the rhythm of the heart at the atrial and ventricular level with one single lead. And what's the importance of this? The importance is that once you implant a pacemaker, single chamber, and you have also monitoring of the atrial events, you actually are able to recognize one important complication of many cardiac diseases, which is atrial fibrillations. So if you just take patients with an implantable device, in this case, this was not a pacemaker, but an ICD, a defibrillator, and you have the possibility to monitor the atrial events, you'll see that 1 out of 5 patients, in fact, has atrial fibrillation that is not recognized. What is the importance of this? Of course, atrial fibrillation has an effect in heart function because of the fast and irregular rate, and has a possibility of causing not only heart failure, but also stroke, because, of course, of the left atrial appendage getting a blood clot that will go into the arteries and will go into the brain and create a stroke. And in fact, if you look at also this problem of atrial fibrillation in patients with ICD, this is also related to total cardiovascular mortality and sudden cardiac death. So atrial fibrillation that was underdiagnosed, thanks to the new technologies, in fact, are allowing us to diagnose this problem and treat it appropriately. Now, what is this? Just to show you, this is one of the many technologies, but this is the lead here, yeah, that you have. Going into the pacemaker is a single lead, but you see here you have 2 electrodes, one in the ventricle, one in the atrium, in the same lead. while you can combine this nowadays for cardiac resynchronization therapy, one lead in the right ventricle with also electrodes in the right atrium, and then one lead in the left ventricle to resynchronize the contraction of the heart. And that's also, of course, to the benefit of our patients. Now, let's go now to the most important thing for the rhythmologist, ablation. eh? We discussed already the ablation of atrial flutter in the first presentation. Of course, let's say the big milestone in rhythmology in terms of ablation was done by Dr. Borgrefe in the 80s, when he ablated the first accessory pathway in the heart using radiofrequency ablation. Here you have the circuit, the tachycardia going around. There's the electrical impulse that goes up the accessory pathway. We have seen this. Yeah, this is the tachycardia. And the reason why the patient gets a tachycardia is one, and a single one, is simply the accessory pathway. So if we destroy the accessory pathway, we will simply cure the problem. And you see here the tachycardias. This is a typical circus movement tachycardia, QRS complex, P wave after the QRS complex. Here we have another circus movement tachycardia, but you see that the P wave is now later, is before the QRS complex. This is the classical fast accessory pathway of the Wolff-Parkinson-White syndrome. This is the typical Kumel tachycardia, we call that, because Dr. Kumel from Paris described this arrhythmia, where the accessory pathway, instead of conducting fast, is conducting slow. Here, the RP interval is about 140, 160 milliseconds. Here, the RP interval is 300 milliseconds. So these are two accessory pathways, fast conducting, slow conducting. Now, what we do, exactly the same as with the flutter, we use technology. Here you see some old technology, old computers, but as they are still working, we use them. We do not throw away our material if it's working well to just get a new, more fancy machine. If they work, we just keep on using that. Here you have the electrophysiology catheters. I'm sorry, which just to show you what is the most important thing. These are electrodes to record electrical activity. And here we have a big electrode, two different types. Here you see the one for ablation here to actually be able to heat, to increase the temperature of this electrode until 60 degrees centigrade. That's sufficient to actually destroy the accessory pathway. And you see here another example. This is also a patient with a tachycardia based on the Wolff-Parkinson-White syndrome. Here you see the pre-excitation during sinurhythm. Beautiful, beautiful here. Right-sided inferior accessory pathway in the right side of the heart. Here you can see we can even ablate patients with multiple accessory pathways. Let's see this electrocardiogram. You see here clearly the Wolff-Parkinson-White syndrome. And actually we are ablating. So the Wolff-Parkinson-White syndrome disappears, but actually does not disappear completely. You can see here another wave. So the electrocardiogram changes, but if you look carefully, you see that there is still a delta wave. This is a second accessory pathway. We change the position of our catheter to a second position for the second accessory pathway. And you see here how this completely normalizes. The electrocardiogram becomes now completely normal. It's difficult to see, I know, but if you look this, you can see here the delta wave, and here there is no delta wave. Look here, delta wave, no delta wave. So the patient is cured of two accessory pathways. The most important problem that we have had, of course, has been the one of atrial fibrillation. The major breakthrough have come from two sides, from France, from Michel Heisseguerre, actually showing the mechanism of atrial fibrillation, and from the other side of Carlo Papone from Italy, developing some techniques to ablate atrial fibrillation in a more easy way than actually it was at the beginning. Look at the prevalence of atrial fibrillation. These are estimates, millions of people that have atrial fibrillation. These are only estimates, a lot of people all over the world with atrial fibrillation each year. And actually, if you look at also atrial fibrillation, this looks very complicated. If you look at the mechanisms, in Wolff Parkinson White syndrome, we have only one accessory pathway that we have to attack. In atrial fibrillation, we are dealing with a very complex thing. There are people, they are talking about rotors in the heart. Other people are talking about the ganglions. Other people about focal mechanisms. Other people about a combination of all of them. In fact, if I can tell you the truth, the problem is that we are still, dealing with some problem with the mechanism. But what has happened is that we have been able to develop technologies to cure atrial fibrillation. And my preferred technology at the present time remains cryo balloon ablation, freezing atrial fibrillation. Why freezing? Because freezing actually stops electrical activity of the cardiac cells, but it does not produce a scar. And scars, actually, like we do with radiofrequency ablation, sometimes can be the reason for other arrhythmias, new mechanisms. Here, it's a complex slide. In fact, we are seeing what happens. This is a unique slide. What happens to the pulmonary vein during cryoablation, and this is seen from a thoracoscopy. So the surgeon has now made a little hole on the chest and is looking inside the heart. Yeah, and we are at the time that we are doing that, we are ablating from the groin with a cryo balloon. You see, this balloon is collapsed here. We inflate the balloon with a gas, which is nitric oxide, that goes to minus 60 degrees centigrade, and we get ice, of course. We are freezing this. And this actually will result in the following. Look at this here. This is the left atrium appendage. This is still the view from the surgeon. So he's looking from actually his thoracoscopic device. And we see here, what do we see here? We see the electrocardiogram, and we see here the activity of the pulmonary veins. This is electrical activity of the pulmonary veins. We freeze the pulmonary veins, and the electrical activity disappears. So we create electrical silence in the pulmonary veins, and like this, we actually go for the cure of atrial fibrillations. Can we do that in other arrhythmias? Sure, we can do that also in ventricular tachycardia. And here we have a nice example. This is a piece of muscle of a patient with ventricular tachycardia. This is in blue a scar. And here you have now the reentry circuit in the myocardium. Remember the first slide of the first presentation with that reentry circuit in the ventricle? You see that this is going around the scar like this. This is the ventricular tachycardia. And we can map that. We can go and put our catheter in that area. We can ablate. And you see that when we ablate, we actually will terminate the ventricular tachycardia and cure the arrhythmia. So this is, of course, it's a complicated thing. It takes time to find these isthmus. There are technologies that we use for that, non-imaging technologies, computers, etc. But it is possible to locate this area and actually cure the arrhythmia. Look at this. I'm just showing you here now another thing, which is a patient with Brugada syndrome. And in fact, this is the right ventricle. And the problem is located here, in just below the pulmonary valve. This is the right ventricle. This is here the tricuspid valve. Here we have the pulmonary valve. Here we have the superior vena cava. Somewhere here the inferior vena cava, and the right ventricular outflow tract just below the pulmonary valve. There we have the problem of the arrhythmias. We see abnormal potentials there, and actually we ablate this area, and we can also try to cure Brugada syndrome at the present time, something that we are doing. So, in fact, what we have seen to conclude this presentation is the following. First of all, we have, as general practitioners, to be aware of the fast-growing technologies that actually are coming in the world of cardiology. Why? Because these technologies are benefiting our patients. And in fact, as a general practitioner, we have to know that to be able to refer our patient appropriately for treatments that, as I was telling you and I was showing you, in many cases are curative. They will be able to cure our patients. We have better drugs, certainly, at the initial moment of the implementation of the new drugs at expensive. They are expensive, high prices, but as you know very well, once they are implemented in the world of cardiology, the price, or oncology has the same problem, the prices go down. Unfortunately, this is something we cannot control as physicians, but still we have to know that they are coming and we have to be aware of them. In interventional cardiology, we are able to treat almost everything with less complications, as effectively as surgery, which has done a tremendous good job in the last decades, without any doubt, but is now becoming, as everything is progressing, like electronic technology went from being big machines to micro technology at the present time. We have the same with our techniques to cure our patients. We had major surgery in the past, and now we are going to percutaneous technique with much better functional recovery of the patient, less complications, etc. Something that, in fact, is actually, changing completely the prognosis of our patients and the life expectancy of our patients. We are able to cure almost, I would say almost, not to say every single arrhythmia, but almost every arrhythmia, avoiding lifelong medication for those patients. We can correct asynchrony of the heart. Please remember this patient with left window branch loop. Anytime you see left window branch loop, think, is this patient a candidate for resynchronization therapy? Without any doubt, if you have the correct one, you will be able to basically cure the heart failure of your patient. We have new monitoring devices, imaging techniques, and in fact also assisting devices that are helping us to treat cardiogenic shock. Now, what do I have as advice to you as general practitioner? And I'll tell you, there is this practice in cardiology and practice in general medicine. These are these little websites that are actually led by my good friend, Dr. Doc Sipes, one of the top cardiologists, physiologists, researchers in the world. In fact, a tremendous physician, a tremendous researcher. Please go search for this because I use that as a general practitioner. Also, I am subscribed to this. Every single day you will get on your email, two mails, one on cardiology. There are other sites, but one in cardiology and one in general medicine that will help you to actually get the latest information summarized for you very specifically, sometimes with a comment by an expert about that will help you to keep up to date with all this. It's very difficult. I know myself. I have difficulties. I cannot read all the medical papers. It's impossible. There are so many publications. So that's the good thing, is that we have now these little summarized publications. Every single day you get one, of these publications with 4 or 5 topics telling to you, look, this is new. This is the latest thing that has been published in that area, in my case, cardiology. But as I was telling you, I'm also subscribed to the general as a general physician. And I think that, I hope that I have shown you that the world is changing extremely rapidly in cardiology. So rapidly, I was telling you that it's so difficult to follow, but to the benefit of our patients. And I believe that in the next years, what you will see, and particularly the young people, I'm so jealous of what you will see in the next decades that, probably I will not see, because this medicine is becoming even more and more fascinating than it ever was. I hope you enjoyed this presentation, that you learn a little bit about the new developments in cardiology, and I will be happy to answer any questions that you might have. Thank you very much for your attention.
Thank you very much, Professor Brugada for that excellent second segment of our program. And it was fascinating to see some of the work you have carried out in the form of ablations, that you have shown some slides of nice slides on 3D mapping and ablation in the Brugada syndrome, the context, which I'm sure you have the best of expertise in the world. Before we get into that level, if we have time, we'll try and discuss some of that. But before that, since the audience has number of questions, we have received number of questions, and we had to select some of it, which are more suited for the scope that we are covering today. And may I take your valuable time to present a couple of these questions. The first question is about starting with the Brugada syndrome itself. One of our audience members want to clarify the significance of the Brugada ECGs, especially in the context of type 2 and 3, in patients who are physically fit or to the level of trained athlete or physically otherwise fit people. Are we going to clear them straight away, or do you want to assess them in any other way? He's clear that type 1 Brugada syndrome, you would not disregard. You give due significance to that pattern. The question is on the type 2 and type 3.
That's a very important question, because there is a growing population of individuals in whom an electrocardiogram is recorded just as a screening, for instance, and then that you might find, let's say, what we call a type 2 or 3 Brugada pattern. Now, it is very important, first of all, to have the correct type 2 or type 3 diagnosis, because type 3 basically is a normal ECG with a little bit of, looks like an incomplete right bundle branch block, in fact. Yeah. That's one thing. The type 2 has a little bit of a ST-segment elevation. Now, you have to realize that on itself, these two type 2 and type 3, they are not diagnostic. You cannot make the diagnosis of Brugada syndrome based on this. You need a type 1 electrocardiogram. Now, you have to be very careful not to overdiagnose Brugada syndrome. Yeah? Because I have seen patients that they have what it looks like a type 2 Brugada electrocardiogram, that if you look carefully, this is just a normal ECG with a little bit of an incomplete right bundle branch block, a little bit of ST-segment elevation, but it's just a normal variant. Now, you have to look at your patient and say, well, why I am recording this EKG? What is the background of this patient? Is that a patient that is coming from a family with Brugada syndrome? Well, that's very different. That is just one ECG that you record in an individual without any symptoms, without any family history of sudden death or anything else. In case that you actually are doubting about the diagnosis, okay, then, well, you'll have to perform a pharmacological test. And that of course, will have to be done by the cardiologist, electrophysiologist in the clinical setting, not in the outpatient's clinic, with all the facilities that are required in case that the patient would develop arrhythmias with the test. And this can be an Ashmalit test, can be a prokinamide test, or a flecainide test, depending upon what you have. But please don't make the diagnosis of Brugada syndrome based on type 2 and type 3 ECG. You have to confirm effectively, as you say very well, you need a type 1 ECG to confirm the diagnosis. And please, at the other side, do not overdiagnose Brugada syndrome, because that's happening a lot because of incomplete right bundle branch block looking like, a type 3 electrocardiogram.
Thank you. May I also ask, what are your thoughts on those patients who, generally speaking, would not have a typical type 1 Brugada pattern, but we often see, especially young males, during high fever spikes, febrile illnesses, they manifest more towards a type 1 Brugada pattern. And that in that itself, would you take it as a significant type 1 pattern, or would you subject them to the same protocol of pharmacological tests?
I would certainly like to be sure that this is a type 1 pattern, so that we will, so you are talking about a patient with what exactly? With some ST elevation? Because, one problem we are seeing now at the present time is when you have very well-trained athletes, they might have ST segment elevation in the right precordial leads, but this is a rounded ST segment elevation, rounded like this, not like the type 1 that we know, but rounded. And this is also becoming an issue because some people is diagnosing Brugada syndrome based upon this, which is a form of repolarization abnormality that we see in well-trained athletes. And we have to be very careful. So again, always we have to be sure, and I think we have to be honest. I mean, there are things that only well-trained cardiologists, electrophysiologists can do. I mean, I don't think that. Let's compare to oncology. We as cardiologists, we are not treating cancer. So when we are talking about a disease which is potentially life-threatening, a disease like Brugada syndrome that can kill your patient, like cancer can kill your patient, I think that the correct thing is that this patient is seen by someone that has the knowledge to make the correct diagnosis and apply the correct treatment. And this is, I'm sorry, and I say, I have been a general practitioner, so I know very well the limitations. Then it's the moment to refer your patient to the appropriate center for the correct diagnosis and the correct treatment. Because we are talking about a potential life-threatening disease. Another thing, we have not to forget that making a diagnosis of Brugada syndrome has a lot of implications for the quality of life of your patient. What I mean by that? Life insurances, applying for, a credit to build a house or buy a house, certain jobs like, driving a truck or being a pilot, etc. So you have to be very careful. It's not just making a diagnosis, you are actually having an enormous impact on the life of your patient. And I believe that this can only be done in a completely specialized center that has the facilities to make the correct diagnosis. We have also, as general practitioners, it's important that we take good care of our patients, but as important as our knowledge is, it's important to know our limitations also and know when we have to refer our patients.
So, thank you very much, Professor, for that excellent comprehensive explanation on that.
You touched upon the significance of Brugada pattern even on the category in the context of driving and flying as well, which are always going to be practically important scenarios as well as for the insurance purposes as well. Moving on to the next area of questions that we have received about patients who are otherwise mostly asymptomatic and physically fit, found to be having bradycardia, initially focusing on sinus bradycardia. If the patient is not particularly symptomatic or having definitive features of a significant SA nodal disease or sick sinus syndrome, but if they are in the borderline category, how would you be your approach, and when would you still decide to offer them pacemakers? For example, there's a case scenario that they have put on a young soldier who's having bradycardia, an occasional episode of dizziness. Of course, the patient seems to be symptomatic, and with a lowest heart rate recorded only at around 40 beats per minute, not less than that. Would you offer a pacemaker for this patient?
Well, we have to be very careful again because, of course, in the same way I was mentioning Brugada syndrome, implanting a pacemaker also has a major impact in our patients. This is once you have implanted a pacemaker, you will continue to replace the pacemaker during the life of this individual, probably. So you know that pacemakers also can have complications. They are not that important in practice, but they can have an infection. You can have technical problems. In practice, that's not the issue. The issue is that giving a device to a patient that might not need the device, it's a very, very hard problem. So, of course, we have to be very careful with the diagnosis of what is real important bradycardia, because the individual, a young soldier that probably is doing a lot of exercise with the training and everything, a heart rate of 40 beats per minute, okay, that's not that important. Dizziness, you have thousands of reasons to be dizzy. You know, you can be dizzy of course, of arrhythmias, but you can also be dizzy simply because you are not feeling well, or because you are just having, a very fast movement when, for instance, jumping out of bed and you get a little bit dizzy. That happens to everybody at least once in a lifetime. So again, you need a correct diagnosis. Is that a normal bradycardia, or are we actually are you dealing with a real sick sinus syndrome? Now, again, of course, you will need some more specialized analysis of this. You will have, for sure, you will need a Holter monitoring. You will have an exercise test to see whether the heart rate is increasing normally during exercise, see what happens in the recovery phase, etc. And you might even go to more sophisticated techniques like electrophysiological investigations that you know very well. They have a limited value in sick sinus syndrome. So, okay, that's a complicated issue, but be careful not to, again, overdiagnose sick sinus syndrome and give a pacemaker to a patient that do not require the pacemaker. Again, I think this is an important step in the life of our patients. This is something, again, that should be decided by a trained center, with the facilities, cardiology, electrophysiology, to make the correct diagnosis and implement the appropriate therapy. On the other side, we have to realize that sometimes, but I'm now not talking about this young individual with 40 beats per minute. Let's take someone who is 65 years of age, and who has, symptoms of, a little bit of fatigue and everything. And he has also a heart rate of 40 beats per minute, the lowest one. But you put it on the bicycle and you see that this heart rate is not increasing appropriately. Yeah. Okay. And it gets only to 65, gets only to 70, 80 beats per minute, no more than that. And, okay. And, then you go and you have a diagnosis of inappropriate increase of the sinus rate. So this might be a sick sinus syndrome. You might get the surprise, effectively, this is the other side of the spectrum. You implant a pacemaker and all of a sudden this patient says, wow, now I can do everything I want again. And so these are the two sides of the spectrum, of the presentation of sick sinus syndrome. The patient that has some symptoms and that we are suspecting a disease, but does not have the disease, and the other one that has only also a little bit of symptoms, we are suspecting the disease and has the disease, but you can only show it retrospectively. So I'll be very careful, particularly in young people with the bradycardia. Young people, my well-trained athletes might have heart rates of 20, 25 beats per minute during the night. Yeah, 20 to 25 beats per minute. So and they do not have sick sinus syndrome. When you put them on the bicycle and they go on the mountains, they go to 200 beats per minute. Again, I think this is a question that you might suspect sick sinus, then let's have the appropriate test and the appropriate context to see, is it or not sick sinus syndrome? And I agree, sometimes it's very difficult. No.
Of course. Thank you very much. I think we have almost reached 2.5 hours limit.
Just one other question we would like to entertain, if you can, with a lot of appreciation. Right. Thank you. Since you have mentioned about this category of patients, the trained athlete or professional level athletes, And we do see the sensitivity of patients who have borderline low ejection fraction. When one subject them to a conventional echocardiogram, you might see an ejection fraction of about 45 to 50, something like that. And what would be your approach on these patients?
Of course, depends a lot on the context. Indeed, is the patient coming for a routine screening, and we find that we will be worried that he might have some sort of disease that we still, will have to try to diagnose in the next steps. Is different if the patient has, family history of already of congestive cardiomyopathy that might be caused by lamine mutations, hereditary disease, and he might be in the initial phase. Of course, it depends a lot on the context. 40%, of course, is not normal at all. That's already worrying, to be honest. What we are seeing is, and I don't know whether this is the case also in Sri Lanka, we are seeing with using MRI, more and more athletes who have a scar tissue, in fact. And this scar tissue that it looks like, but it's very difficult to prove that it could have been caused by a myocarditis. And this is a big problem. Look, we just have now in the local press and the national press, and also a little bit in the international press, we have, just before I left Belgium, we actually did an ablation, a cryoablation, epicardial cryoablation of a football player here who is called Fadiga, and actually a very promising young guy, and he had exactly what you are describing now. So a reduced ejection fraction, about also 40%, and then with a scarring of the apical part of the ventricle, of the left ventricle. And what we have done has been a cryoablation of that area, and we have had to implant a defibrillator. The funny thing is that actually 30 years ago, I had to do the same, exactly the same, with the father. The father, and we have done a lot of genetic tests and everything. Excuse me. And we found nothing. So we have not found anything that is hereditary. So it seems that the father 30 years ago had some sort of myocarditis, and the son now has exactly the same problem. The father, by the way, Kaliu Fadiga, he was the first soccer player that played professional football with a defibrillator. And he was playing with the Bolton Wanderers in England. And when I allowed myself and the doctor of the team allowed him to play, we were hung by our colleagues. They say that we were completely gone nuts. Nowadays, you know that fortunately the situation has changed. And I think that if you look at the more recent one, Eriksson from Denmark, a very well-known soccer player, he actually had a cardiac arrest, got a defibrillator, and the first match he played was against Manchester United, and he made 3 goals, actually. So that you see that with a defibrillator, this is not the end of the life. This is the beginning of a new life with protection. And that's, I think it's important to give also always a positive message to our patients. But in the case you are mentioning, I think that the first thing I'll do was a cardiac MRI, of course, coronary angiography, etc., but to see whether we are dealing with a possible case of myocarditis, because, the echocardiogram will not give you the clue. You need to see with, late enhancement on the MRI, see whether this technology allows you to diagnose scarring as a possible result of a myocarditis. That would be our first approach. I think that.
Thank you very much.
Thank you. No. I mean, I think that cardiac MRI has also changed completely our approach to muscular disease of the heart, to cardiomyopathies, completely.
Thank you very much, sir, for all your generosity in contributing for continuation of medical education for the population of doctors in Sri Lanka. And we really appreciate your excellent academic inputs in the form of 2 topics. And we will be immensely appreciating you, and we'll be in touch with you in due course. And we are looking forward to try and get you for future events as well. I would now hand over the proceedings to my colleague here, Dr. Rajiv Menon, for concluding remarks. Thank you very much, sir. Thank you.
Thank you very much, Dr. Susantha Amrasinghe, for coming all the way from Teaching Hospital Karapitiya and hosting this high-profile CPD lecture and providing your expertise and communicating with the Emeritus Professor Dr. Pedro Brugada. So this marks the end of a historic lecture, making it the highest participated CPD lecture which we have conducted so far by the Government Medical Officers Association of Sri Lanka. So thank you very much, Prof. Pedro Brugada, for making a historic presentation for all the doctors in Sri Lanka. So we are only 65,000 square kilometers big island, but we have more than 20,000 doctors who are registered with us. So we have shared the link with all of them. So I think majority of them have participated in this lecture and surely would have updated their knowledge with all your expertise. So I take this opportunity to thank President GMOA, Dr. Sanjeewa Tennakun, Secretary of GMOA, Dr. Prabhat Subitadasa, Exco of the GMOA, and of course Dr. Prasad Herath, Assistant Secretary GMOA, and the Exco focal point of the academic subcommittee, who worked tirelessly behind the screen to make sure that this lecture happened today, especially on his birthday, to make sure that this lecture was happening on his birthday. He worked tirelessly. So we are the people who are in the front, but there's a whole team behind us who is supporting all of these things, coordinating a lot, and Dr. Prasad Herath is right in front. So we'll also wish a very happy birthday to Dr. Prasad. And finally, would like to thank the membership who connected with us live from all across Sri Lanka and spent 2.5 hours of their time listening to a high-yield lecture by Prof. Pedro Brugada, which I think is once in a lifetime opportunity for most of our doctors. So thank you very much to the membership for being a part of the history. And that concludes the proceedings for today.
Thank you.
Yeah, and we thank Prof. Pedro Brugada again for connecting with us, and do stay online. We will be having a little bit of more discussion with you offline. So to the membership, hope to meet all of you in a fortnight's time with another CPD lecture brought to you by the Academic Subcommittee of the GMOA. Thank you.